This video is about interpreting ECGs. We will cover the physiology behind the ECG and pattern recognition of common arrhythmias. So what is an ECG? An ECG is a trace of the electrical activity of the heart. So let's go through the electrical activity of the heart and how it corresponds to an ECG. Electrical activity starts at the sinoatrial node located in the right atrium near the crista terminalis. This triggers atrial depolarization, which manifests as a P wave. A large P wave would hence affect atrial hypertrophy as more voltage is produced from a large atrium. From the sinoatrial node, impulses travel to the atrioventricular node, and this reflects the PR interval shown here, though strictly speaking, I guess it's the PQ interval. A short PR interval suggests that impulses may be traveling through a shorter or an accessory pathway. An example is Wolff-Parkinson-White syndrome, which also has a delta wave before the QRS. From the AV node, the impulses travel via the His bundle to the ventricles. Purkinje fibers in the ventricles respond to these impulses to cause contraction, and these impulses, or depolarization of the ventricle, is reflected by the QRS complex. Now, there are four things to look at in the QRS complex that are put at the bottom. So first, there may be a physiological Q wave, so a small Q wave before the QRS, and this reflects the left ventricle depolarizing first because it is larger than the right ventricle. It is normal. Then the width of the QRS. If it is wide, it means ventricular tachycardia, and if narrow, supraventricular tachycardia. Next is height. So tall QRS may reflect LV hypertrophy, similar deal as the P wave. Finally, there may be pathological Q waves or Q wave after the QRS, which reflects previous infarction. Then the ventricles repolarize, and this is shown by the ST segment. A local elevated ST segment means infarction and depression ischemia. Widespread ST elevation with PR depression suggests pericarditis. Take note of the lead placements and which leads affect which areas of the heart. Knowing this will tell you which area or artery is affected when there are those ST changes. To calculate the axis, we compare lead 1 and AVF. Positive or negative in the table here shows whether the net height of the QRS is positive or negative, so comparing the upstroke to the downstroke. The table shows how that relates to the axis. The heart may be deviated to the left due to the left ventricular hypertrophy, left bundle branch block, which we'll get into later, or Wolff-Parkinson-White syndrome. The heart may be deviated to the right due to right ventricular hypertrophy or lung issues such as COPD or PE. Okay, now different arrhythmias. So first degree heart block occurs when there's a blockage between the SA node and the AV node. So this is shown by a prolonged PR interval. In second degree type 1, the PR progressively lengthens until the QRS disappears. In second degree type 2, the PR interval is constant, but then the QRS disappears. The difference in PR is because whilst Mobert's type 1 is usually due to suppression of AV conduction, Mobert's type 2 is more likely due to failure of the conduction within the His-Purkinje system. Finally, in third degree heart block, there's disassociation between P waves and the QRS complex, and this is reflective of there being atrium and the ventricles contracting in a discordant manner. The atrium may fibrillate due to abnormal SA node function. Remember, the SA node starts conduction through contracting the atrium. Hence, in atrial fibrillation, there are no P waves and an irregular rhythm. Atrial flutter has a similar mechanism to atrial fibrillation, but has the iconic sawtooth appearance. Moving down the atria, there can be a junctional escape rhythm. So the SA node fails as the dominant pacemaker, and instead it originates in the AV junction. As you can visualize, this would cause atrial depolarization in the opposite direction, and this is why you get an inverted P wave. It is also important to be aware of electrolyte abnormalities as they can influence treatment. Hyperkalemia has a tall T wave, and in severe cases a flat P wave and bizarre QRS. Hypocalcemia has a long QT segment, and vice versa. A bundle branch block is where the His bundle to the Purkinje's is blocked, and in a left bundle branch block, the left side is affected. So the right ventricle would depolarize first and then travel across the septum to the left side. And this means it takes longer to depolarize, leading to a wide QRS, and you can also get T-wave inversion. It is also common to have ST elevation as shown here. And so when trying to diagnose an ST-elevated myocardial infarction or a STEMI with the left bundle branch block, it can be difficult, and that's why you need to use Carbosa's criteria. William-Morrow is a good way to remember left and right bundle branch blocks. William means you see a W in lead V1 and M in V6 in the left bundle branch block. If it's right-sided, you see an M in V1 and a W in V6. The two peaks in the W and M are because you have to think about the definition of bundle branch blocks. So the impulse in one side is blocked. You can only reach that side after traveling to the other side and via the septum. And this is unlike normal when ventricles more or less depolarize in sync and give you one peak. Finally, Whelan's sign indicates severe left anterior descending artery stenosis and is an emergency. It can either have inverted T wave or a biphasic T wave. Thank you for watching. If you learned something, please tell a friend who may also find it useful.